Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician.
Welcome to the LACNETS podcast. I'm really excited to introduce today Dr. Pamela Kunz. Dr. Kunz is an associate professor of medicine in the Division of Oncology at Yale School of Medicine, where she also serves as the director of the Center for GI Cancers and the Division Chief of GI Medical Oncology. And she received her medical degree from Dartmouth, her postgraduate training, including medical residency, chief residency, and oncology fellowship at Stanford University School of Medicine. Dr. Kunz is an international leader in the treatment and clinical research of patients with GI malignancies and neuroendocrine tumors, and she holds several key leadership positions in the field, including President Emeritus of the North American Neuroendocrine Tumor Society, or NENs, recent past chair of the Neuroendocrine Tumor Task Force of the NCI, and is a standing member of the FDA's Oncology Drug Advisory Committee. She was recently appointed the editor-in-chief of the JCO Oncology Advances, and in addition to her focus in NETs, one thing we're really appreciative about is that Dr. Kunz is a leading voice for promoting diversity, equity, and inclusion in medicine. And she served as the vice chair of DEI for the section of medical oncology at Yale School of Medicine, and in 2021 was awarded the Woman Oncologist of the Year by the Women Leaders in Oncology for her work in promoting gender equity. Congratulations, Dr. Kunz. And on a personal note, I just wanted to share that aside from my husband's NET medical oncologist, who we started seeing almost immediately after he was diagnosed, Dr. Kunz was the first NET expert I met outside of that. And I was so impressed by her knowledge of NETs, how well she explained things, and then also when I went up to talk to her afterwards, her incredible kindness and compassion. Oh, one more thing. The fun fact is that she has 3 sons and she spends most of her time on baseball fields supporting her sons. So welcome, Dr. Kunz, to the LACNETS podcast. And if you don't mind sharing a bit about how you got involved in the NET world.
Thank you, Lisa. So happy to be here. So how did I get involved in the NET field? It was a little bit of serendipity as I was finishing, or actually really I think it was in the beginning of my oncology fellowship. I had a mentor who suggested I write a review paper on neuroendocrine tumors. And at the time, this was like in 2005-06, there were very few approved drugs. So it was kind of at the beginning of when we were starting to see new clinical trials in that space. So to me, it was a really exciting time to get involved in a new field where there was lots of opportunity and we really needed new treatments and new diagnostic tools. And so I think I became interested and really loved taking care of patients with NETs. And then the science of neuroendocrine tumors was really, I was drawn to it. So I think it was just a mix of things.
Yeah, you were up for the challenge and you really have paved the way for more diagnostics, more treatments, and we really thank you for your work in that area. So in this series, we've been talking about a lot of different treatment options, and we've talked about somatostatin analogs, we talked about PRRT, and so this month we're talking on chemotherapy. It's the big C word, and it can be really scary. Lots of associations with other types of cancer. So if you don't mind explaining what is chemotherapy broadly and how does it work, and then we can go into what it means for neuroendocrine cancer.
Sure. You're absolutely right, Lisa, that chemotherapy has the stigma associated with it. I think patients may come in with having had experiences with friends or family members, and not all chemotherapy is created equal. They're really very different. And I would say that over the years, we've also gotten a lot better at supporting patients through chemotherapy with other supportive medications. So maybe we can later spend a few moments on that too. But chemotherapy broadly are treatments that attack rapidly dividing cancer cells. That's just sort of a broad term, and it's sort of an umbrella term that captures both IV forms of chemotherapy and some pill forms of chemotherapy. Different chemotherapies may have different mechanisms of action in terms of how they target rapidly dividing cancer cells. This is really different than what we would call a targeted therapy that targets a specific tumor growth pathway or a specific receptor on a cell surface. So chemotherapy really targets rapidly dividing cancer cells.
Okay, targeting rapidly dividing cancer cells. So what does it mean for neuroendocrine cancer, when are they used and what types of neuroendocrine cancers are they used for?
Well, I think one key is that because neuroendocrine tumors, the grade 1 and 2, tend to be slower growing, many chemotherapies are not best suited for those. Typically, we think of chemotherapies for many of our faster growing cancers. So I'd say one of the first places we used chemotherapy were in neuroendocrine carcinomas. These would be our poorly differentiated or faster growing neuroendocrine cancers. And so we've used things like platinum etoposide. For many, many years, these are IV chemotherapies that are given in combination. Chemotherapies, I should also say, are given in cycles. So that particular chemotherapy is given 3 days in a row, carboplatin on the first day, etoposide on days 1, 2, and 3, and then it's repeated every 3 weeks. And the way we determine success for chemotherapy, really many of our treatments, is getting regular scans, typically CT scans or MRIs, and those would be taken at regular intervals, like every 2 to 3 months. So a rapidly dividing neuroendocrine cancer, like a neuroendocrine carcinoma, will often be fast growing, but then the silver lining is that it may respond quickly to chemotherapy. However, often the durability of that response may be short, so the response may not last for very long. So that's sort of one type of chemotherapy that we use. The chemotherapy that I was most intimately involved in was a clinical trial that used temozolomide and capecitabine versus temozolomide alone for patients with pancreatic neuroendocrine tumors. Now, this is actually the slower growing variety of neuroendocrine cancers. So these are grade 1 and 2 or well-differentiated neuroendocrine tumors. And it's long been known that for whatever reason, pancreatic NETs tend to respond a little bit better to chemotherapy than small intestine neuroendocrine tumors. There was an IV chemotherapy that was approved in the 1980s called streptozocin. And this is in a class of chemotherapies called an alkylating agent. That just refers to the mechanism of action. And a newer alkylating agent, temozolomide, was developed, and it has fewer side effects, and it's a pill, so it's a lot easier to take. And so this particular clinical trial really capitalized on the idea that, well, we know alkylating agents work, but can we use it in a way that's better tolerated for patients? And so capecitabine is another pill, and they have different mechanisms of action. And so they were paired together where patients get 2 weeks of chemo and then 2 weeks off. So that 4 weeks is considered one cycle. The way those pills are dosed, capecitabine or Xeloda, as it's also known, is taken twice a day for 2 weeks in a row. And then the temozolomide or Temodar, and we often call that Captem, is taken for 5 days at the end of that 2 weeks. So if we number those days 1 through 14, patients are taking capecitabine twice a day, days 1 through 14, and Temodar they take once a day, days 10 through 14. And then a 2-week break. And similarly to define success, we get scans about every 3 months for those patients.
Yeah, I'm glad you brought that up, and thank you for your work on such an important trial. How is that determined that it's this magic combination of the day 1 to 14 of the Xeloda and then just the 5 days of Temodar? And then also, how long does one take that for?
Good question. I think that it's a good question of how that dosing schedule came about. My understanding, I was not involved in the original design of that, but both of these medications are given in many other cancer types. And so I think we borrowed some principles for how they were dosed. We know that it's helpful to do some breaks after people get sort of a period of chemotherapy. It's, I would say, rare with chemotherapy that we do it continuously. There are some targeted therapies that we do that with, but chemotherapy, we often build in these breaks. There's some thought that capecitabine may actually help prime the cells. And so taking that first before they get the temozolomide is thought to be helpful in terms of making it more effective. The clinical trial required patients to take it for a maximum of 1 year. And the reason it was designed that way is that temozolomide, when it was historically used in other cancers, it was actually dosed more frequently and can increase risk of infections. And so it was felt that for this particular dosing, even though it's actually dosed much less frequently than it was in those other situations, that it might be best to limit it to 1 year.
So how do you decide who goes on Captem versus other kind of therapies?
So CAPTEM, I reserve primarily for patients with metastatic pancreatic NETs. So that's important. I think that, I may see some people who are coming for another opinion and may have been recommended CAPTEM for small intestine NETs. I think we just have less data. So personally, I don't use CAPTEM for small intestine neuroendocrine tumors. We probably need more data in that, but I think in general, the response rates are quite a bit lower. And I use it for patients that may have bulky tumors. So that means maybe they're larger tumors in the liver. Perhaps they're causing pain or other symptoms. And this is because CAPTEM has one of our highest shrinkage or response rates. Therefore, if someone is symptomatic from their tumor, I want to choose a medication that has a chance of tumor shrinkage. And so I will often go to CAPTEM for those patients.
Okay. And actually, that was my next question. What is the goal of treatment with CAPTEM versus some of the other drugs, and how you go about thinking about that?
Yeah, that's a great question. So, many of our therapies for neuroendocrine tumors, and I'm going to focus now on the well-differentiated neuroendocrine tumors in this conversation, many of the medications or treatments yield stability or disease control, which is still a win as long as patients are feeling reasonably well. I think if we can string together lots of treatments that yield disease control and allow good quality of life and can do that for many years, that's really a success. I think for patients that need objective tumor shrinkage, we need to be thinking slightly differently. So if I see a patient who has very low volume disease, is not symptomatic, I might consider a medication like a somatostatin analog, like lanreotide or octreotide. Maybe we'll just talk about pancreatic NETs since it's a little bit easier. So we could use those agents. Other approved agents include biologic or targeted therapies that include things like sunitinib and everolimus. Those are both pills that target specific tumor growth pathways. And then we also have lutetium dotatate or Lutathera, approved for metastatic pancreatic NET, and CAPTEM. And so I would say the most common decision that I'm having to make is the decision between CAPTEM and ludotatate. And there's actually a clinical trial that's studying that. So I think there is equipoise between that choice. They both have been studied in pancreatic NETs. We know they're safe and effective. We just don't know how they compare to each other. So this is a national clinical trial, network trial run through the National Cancer Institute that is looking at exactly that question. Half the patients get CAPTEM, half get lutetium dotatate. The other thing I tell patients, I actually just had this conversation with a patient yesterday, is that most patients will get all of these therapies in their lifetime. I think we are at a place in the field right now where we don't necessarily know the optimal sequence. And so some of that requires expert judgment. It's very tailored to the patient depending on what symptoms they're having and where the cancer is in their body.
Thank you so much. That was a really helpful explanation of how you go about thinking. And thank you for bringing up the clinical trial, because really these are the questions that we all have. Which one should we choose? How do we go about making those decisions? Well, this is an opportunity to be part of the future to help answer those questions. I guess I also wanted to ask, I know you're bringing this up for pancreatic NET, sometimes it's used for small bowel NETs. What about lung NET?
Yeah, great question. So I think this is certainly amongst NETs, one of the least well-studied areas. So at present, our only FDA-approved treatment for well-differentiated lung NETs is everolimus. There was a small study of lanreotide that closed early. I think as a practicing NET expert, I will sometimes use somatostatin analogs. It's not officially FDA-approved, so that's the disclaimer, but it has been studied. There's a clinical trial looking at lutetium dotatate versus everolimus in lung NETs. And then I will sometimes use CAPTEM off-label. And I think this is where you need to go see a NET expert, because I think we have a lot of experience in treating many patients. And I think that for a specific patient who may be in need of tumor shrinkage, that may be a therapy that we can try.
Yeah, thank you so much. And it really highlights
More trials.
the importance of more trials, more data, and also seeing a NET expert, how important that is, because you understand what has been done for other cancers, what has been done in the field of NETs, and what works and could work for each specific situation. People deserve that these decisions are tailored to them.
Right.
One other chemotherapy I did want to bring up that doesn't get a lot of attention in our NET discussions, and when it gets brought up, there's a lot of, I've never heard of this, is FOLFOX. So oftentimes we hear this in our question and answer sessions. What about FOLFOX? I've never heard of it. How come you guys don't talk about it? When is it used? And why don't we talk about it more?
Yeah, no, really good question. Actually, Dr. Emily Bergsland and she's at UCSF, she and I did separate studies examining FOLFOX back over a decade ago. So FOLFOX, for our listeners, is an acronym. It stands for 2 active chemotherapies, and there's one extra drug in there that helps one of them work better, but it stands for 5-FU, which is an IV infusion, oxaliplatin, which is an IV infusion, and leucovorin is the non-chemotherapy drug, but it helps the 5-FU work better. This is the regimen and how it's given. The 5-FU is infused over 48 hours through a pump that patients go home with. Sounds a little crazy, but you can put it in a fanny pack. I've had women put it in their purses. So it goes with you for 48 hours and then you go back and get disconnected. The oxaliplatin is an infusion that goes in over about an hour and a half, 2 hours, and that's repeated every 2 weeks. Indications for FOLFOX will include similarly patients who may have more rapid pace of growth, both small intestine and pancreatic NET. I don't typically use that regimen for lung NETs, but these would be all GI NETs. Maybe we've tried some of these other therapies like lutetium dotatate or CAPTEM, and we're needing another option. Sometimes for patients that we may see a change in biology, maybe their disease has been very slow growing for many years, and then suddenly we see an increase in growth or a sudden increase in growth, and then we will consider using FOLFOX. It's also great for patients that can't take pills. So there are some patients where either for prior surgeries they've had or other reasons, pills might be difficult. FOLFOX is all IV, or if patients have difficulty with absorbing pills, we may consider an all-IV regimen. And one other fun fact is that capecitabine is actually almost the identical drug to 5-FU. It's considered a prodrug. It's a newer formulation, but they're really the same drug, just in different formulations.
So naturally, a question would come up, when would you choose CAPTEM versus FOLFOX?
I think there's better, higher level of evidence with CAPTEM in a specific prospective study for pancreatic NETs than for FOLFOX. So I would use that first for pancreatic NETs. For my patients with small intestine NETs who have rapid growth, bulky tumors that are in need of tumor shrinkage, I will consider FOLFOX. And I think one challenge is that for patients with small intestine NETs, we don't have as many drugs that yield objective tumor shrinkage. That's a high need for our field. So sometimes I'll go to FOLFOX earlier for those patients as needed.
Okay, thank you. And does the grade matter in terms of when you would go to FOLFOX versus CAPTEM?
Yep, absolutely. I'll answer in a couple different ways. I would say that certainly I'm more worried if patients have a well-diff grade 3 tumor that they may have more rapid pace of growth. So it might make me think about starting something that has an ability to shrink a little earlier in a disease course than waiting. Really, for any grade pancreatic NET, CAPTEM is reasonable to consider, but I think as we're getting into the well-diff grade 3, I might not start an SSA first. I might consider CAPTEM. And in general, for PNET, I would start CAPTEM before FOLFOX in almost every patient, just given the high level of evidence.
Yeah, okay. That's really helpful. I know a lot of times we can't compare one to the other, but does one work better or faster at shrinking tumors, FOLFOX or CAPTEM?
They've never been compared head to head, so we don't really know. I think I'll add a question is, do we know if one is better than another of lutetium dotatate and CAPTEM? And again, I'll remind our listeners that the NETTER-1 trial that led to approval of ludotatate only included small intestine NETs in that original trial. A subsequent trial, NETTER-2, did include prospectively pancreatic NETs, and we're still doing analyses that are looking specifically at the differences between small intestine and pancreatic NET response rates, but it's thought that actually pancreas tends to have higher response rates. So I think that's back to why we do clinical trials. This idea of comparing ludotatate directly to CAPTEM will really give us a better sense of which yields higher response or shrinkage rates and which has longer disease control. And so, but truly the FOLFOX versus CAPTEM, we just don't know.
So there's options for NETs, and it just varies on the situation. And I guess this is a good time to shift into the side effects. And you were talking about various side effects and supportive measures. So what kind of side effects might one have?
So it's really dependent on the chemotherapy. Some are general. So I would say general chemotherapy, the side effects can include fatigue, some nausea, often changes in lowering of blood counts, like red blood cells, white blood cells, and platelets. So those get monitored. There are some unique side effects to specific chemotherapies. So for example, capecitabine can cause diarrhea. It can also cause increased freckling or darkening of creases of palms and soles, or sometimes dryness of palms and soles. And temozolomide specifically can cause increased nausea. So actually we give preemptively an anti-nausea medicine on days patients are taking temozolomide to try to prevent nausea. And actually that's a pretty common tactic. If we know, for example, that a chemotherapy has a higher risk of nausea, we actually try to be proactive about that and give anti-nausea medicine. So for all of the IV chemotherapies that I mentioned, Folfox or carboplatin, etoposide, there are anti-nausea medicines built into that plan where patients are given those 30 minutes to an hour before they get the chemotherapies.
That's helpful. You mentioned the counts going down. Does that mean that someone's immunocompromised?
Good question. So typically, immunocompromised would refer to if the white blood cells are low. And all of these treatments can potentially do that, which is why we monitor blood counts pretty regularly. If your white blood cell count is low, specifically neutrophils and or lymphocytes, those can increase your risk of certain types of infections. And so that's good to just check with your doctor. Another common question I get asked is, can I go get a dental procedure while I'm on chemotherapy? And I usually recommend patients get their blood counts checked before they get a dental procedure, both in terms of risk of infection, but also to check platelets, because if you have a dental procedure, you may have an increased risk of bleeding if your platelet count is low. So just lots of good communication between your dentist and your doctor. Or if you have any other procedures, good to just get your blood counts checked before you consider any of that.
Yeah, thanks for highlighting that. Sometimes when we think about counts as a patient or caregiver, we're only thinking a part of it, but there's so many factors to weigh in. And a common question is, will my hair fall out? Is it like other chemotherapies?
Yeah, I think that many patients ask that. I would say especially our younger patients will ask that. And I think especially because it makes patients look different and they really want to be prepared for that. So there are some chemotherapies that cause hair loss and hair thinning and some don't. So I would say Cap-Tem in general does not cause that. It may cause a little bit of hair thinning, but it generally does not cause complete hair loss. Carboplatin etoposide usually does cause hair loss. Folfox is a bit of a mix. Some people have hair thinning and some do not. What I'm learning as we are now 6 years after the FDA approval of Ludotatate, I think I'm seeing more hair loss and hair thinning in women in particular. It's quoted at about 10 to 15% risk of hair thinning. And I think that we're seeing that. I'm certainly counseling my patients on that a little bit more because I think that can be a really bothersome side effect.
And is there anything that can be done to prevent it or reverse it?
That's a great question. I think it's really an area of ongoing research, certainly in the world of breast cancer, where many of those therapies do in fact cause hair loss. There are some devices that cool the scalp that help reduce the risk of hair loss. I have not yet used that in any of my patients with NETs, but it's certainly something to think about. And those types of devices have also been studied in clinical trials. I'll add that actually there are some new studies using cooling devices to prevent peripheral neuropathy, which can happen with oxaliplatin. So that's the ox of the Folfox. So I think there is a huge increasing interest in these survivorship issues around preventing side effects that can negatively impact quality of life, whether it's your appearance, whether it's neuropathy, which is numbness or tingling in fingers and toes, with much better anti-nausea medications nowadays to really try to prevent nausea. So I think we're getting better. It's not perfect, but I think we are getting better at trying to both prevent and minimize side effects.
That's really helpful. So if someone wants to know more about supportive measures, maybe their doctor doesn't know about the latest and greatest or these cooling devices for scalp or neuropathy, how does one go about finding out more?
many institutions will have survivorship clinics or will have supportive care clinics that may be not specific to NETs, but may be specific to that side effect. So I'd encourage patients to look out for that at their own institutions. I don't know, maybe Lisa, I've given you your next podcast idea if you haven't done this already. But, we can brainstorm and bring in, there's actually ongoing right now, I think it's in France, there's a supportive care oncology conference and professional society that has wonderful experts who really spend their time researching and focusing on managing side effects and new therapies and treatments and how to do that.
Yeah, that sounds like a great idea. We're going to have to do that. So I think the other big question is, how is chemo going to affect my day-to-day life? Can I live a normal life? Can I work and function? How am I going to feel?
I think that it's hard to make broad generalizations because every chemotherapy is a little bit different and every patient responds a little bit differently. I tell most of my patients I wish we had better predictors of who is going to get which side effects and how severe they're going to be. That's something that we aren't very good at predicting. So I think that I usually tell patients to kind of lay low for the first cycle because we get a good sense of what side effects they're going to have, how we can support them through that. For CAPTEM, for example, I would say that most patients can still work while they're on that. There's some nuances there, but honestly, if we're treating a patient where they feel so sick that they're in bed, we're doing something wrong. We need to make modifications to those drugs in order to make them more tolerable. And that's something we haven't mentioned is that often with both pills and IVs, we can make slight adjustments in reducing the doses or even sometimes tweaking how often people get the medications where it's more tolerable. I think another message to the listeners is that if you are experiencing side effects that are not acceptable to you, tell your doctor because there's often lots of things that they can do to make that better tolerated.
That's a really good point. And I know oftentimes on the patient end, you're afraid that if I tell my doctor if I have to go down on the dose or skip a dose, that maybe I'm not getting a high enough dose and it won't be effective or shrink it as much. And people can feel like a failure. So what do you say in response?
So that's a very common concern. And I think what I try to tell patients, and I'll give a story about this, is that we have a lot of wiggle room that allows us to stay within an effective dose range. And what's interesting, on clinical trials, there may be a published dose, but in clinical trial speak, there's something called dose intensity, meaning if you look on average how much chemotherapy patients received on a clinical trial, it's often closer to 75 or 80% of the prescribed dose. So that starting dose often needs to get modified for many patients. Sometimes that's cumulative, meaning after they've had 3 to 6 months of treatment, we may need to start tweaking the dose. Sometimes it's from the beginning. But I think that I would tell patients to not feel like it's a failure if we have to make adjustments, that the medications can still be effective even at lower doses.
Yeah, thank you. And you talked about tweaking. I'm wondering also, can medications be stopped and then restarted later or repeated?
So that's a great question. So I think I'll answer that in a couple of ways. If a patient is receiving a given treatment and is stopped because they have cancer progression, we typically set that aside and will not return to it because I think it typically means that the cancer has become resistant to that treatment. If, however, a patient is given a treatment and we're stopping it because we're just giving them a break, we talked earlier about how often the first course of CAPTEM is given for a year and then we pause. If patients later on have disease progression, we might consider going back to that as long as the reason for stopping was not cancer progression.
What happens during a break in chemo?
So I often use the word strategic break during the course of, I would say for many patients with well-differentiated NETs, sometimes we're able to incorporate breaks that are really meaningful because we're doing it. They need a break from side effects. We're taking a break because they have an important event. And those breaks are often safe. Again, decisions have to be made with your doctor. But for example, in the case of CAPTEM, we might treat for a year, and as long as patients are doing really well, they've had tumor shrinkage, we've seen a great response, we can give a break, and then we're continuing to monitor that patient closely. So we'll continue scans every 3 months. What some of our NET colleagues, Doctors Diane Reedy and others at Memorial did, they actually then looked at, well, what happens after we stop CAPTEM? And many patients actually do well for many months. And on average, patients had stability for about another 9 months after stopping CAPTEM. So again, these strategic breaks often are not setbacks. They help your body recover some from side effects. They have to be done in close monitoring as long as you're getting scans. Typically, these breaks are only done in patients who have slow-growing NETs and where it's safe to do. For neuroendocrine carcinomas, sometimes we'll factor in breaks. It's very case dependent.
Okay. There's a time and place for the strategic breaks, and it can be paused. And then what about combination? Are chemotherapy agents also used in combination with other drugs or more than one drug in the category, as in capecitabine and temozolomide?
So we talked a little bit about some of the combinations that are used commonly. So CAP-TEM is a chemo combo of 2 drugs, capecitabine, temozolomide. Volfox is a combo of 2 active chemotherapies, 5-FU and oxaliplatin. But I would say in general, there is not a lot of enthusiasm for combining, say, ludotatate and temozolomide or ludotatate and sunitinib. The combination of ludotatate and temozolomide has been studied. It has a much higher rate of side effects, specifically lowering of blood counts, and specifically one side effect that's rare with ludotatate that we did not specifically talk about is a risk of a bone cancer called myelodysplastic syndrome. That's only about a 2% risk for patients that receive ludotatate. However, when given together, that risk was higher. So I think for patients specifically with well-differentiated NETs, there's a lot more enthusiasm about sequential treatment rather than combining it all at once. And I think mostly it has to do with increased risks of side effects without a lot of increased benefit.
And that's a really good point. And what about with the sequential treatment? Does taking chemotherapy now, might it preclude someone from getting a future treatment or clinical trial, such as an alpha PRT?
So clinical trials, it depends because all of the eligibility criteria are a little bit different. But for example, there's an alpha PRT clinical trial right now that's open with actinium-225 that allows for patients to have received 4 prior doses of ludotatate, but no more than that. So if you've gotten 6, you would not be eligible for that trial. That's a little hard to know just because as a clinical trial that hasn't been written, you don't know if like what you're doing now will preclude you from going on that trial. In general, for most of the agents that we have available for treating patients with NETs, one doesn't necessarily preclude the other. I would say that the caveat to that is that if you have prolonged side effects from one medication, so let's say, for example, with lutetium dotatate, that you have a prolonged lowering of your white blood count, it might be hard to give future chemotherapy if your platelets are really low, if your white blood cell count is really low. So that happens infrequently, but those are things that we sometimes have to think about.
Okay, that's helpful. And I was wondering, kind of circling back to what I started with at the beginning of the conversation. When someone's told that they have chemotherapy and it's like, what does this mean for my life? Naturally, a lot of people think, is this the worst case? Am I at the end of the rope? How do you counsel them? What do you say?
I'm a big believer in balancing hope and reality. And first, we certainly talk about the disease and define all of the new words that we're having to learn, what it is that they have. We talk about what tools we have available. And I think that that's what's really hopeful right now is that we have all these tools in the toolbox. And it's really just a matter of picking one to start with. And if that happens to be a chemotherapy, I recognize that that word can be really scary. And we try talking about what that means and debunking myths. There are all these myths out there and stigmas and biases against chemotherapy. So it's really just making sure that I create a space to listen. I really love teaching and educating patients and empowering patients. And you guys do a great job of that too. And I think that as long as patients have a really good understanding of what the goals are, debunk the myths about not all chemotherapy is terrible. And in fact, many of our newer chemotherapies are pretty well tolerated. So it's keeping an open mind, even recognizing that some of your past personal experiences with family or friends may be different.
It's not like other cancers. I think that's the hardest thing to wrap our minds around. It may not be like other experiences and what we've heard and seen with other cancers. That's actually a good pivot to the last question, which is, what do you see as the future of chemotherapy in neuroendocrine cancer treatment?
So I'm certainly very hopeful about us both identifying new treatments, some of which may be chemotherapies. I think that the trend is looking at targeted therapies, better peptide radionuclide therapies, But we may find some additional chemotherapies. One novel way we didn't talk about of delivering chemotherapy is delivering it with an antibody that targets things. So there are these things called antibody drug conjugates. So what if we got better at delivering the chemotherapy where we wanted to put it, which is right next to the cancer cell? At present, we deliver chemotherapy systemically. So I would say that that's perhaps on the horizon for NETs. But broadly, I think we've seen just so many advances just in the last decade, which is just crazy to think about. 10, 15 years ago, we didn't have most of the available drugs that we have now. So imagine what we can do in the next 10 to 15. And I think that many patients may directly benefit from the research that's ongoing right now. And I think that's what is hopeful, and I try to impart to patients.
Well, thanks for being a part of that, for being the part of the last 10 to 15 years that's brought us to where we are today, and being a part of the future and creating more opportunities for patients to live better, longer, and really enjoy the things that they enjoy for longer. I really thank you for all you've done in the neuroendocrine cancer world for your patients and to further the field, and for all your care and compassion.
Thank you, Lisa. My pleasure to be on.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Ipsen, ITM, Crinetics, Curium, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.